So next talk is by Dr.Banshi Saboo sir, and he is talking on the Indian outcomes of glycemic with this pump. So Dr. Banshi Saboo sir has already been welcomed, and so maybe I can skip the introduction, sir. Can I?
Yes.
Okay. So that we can have scientific discussion with it. So let me wait for the slides to come. So as you know, sir is working in Ahmedabad, and is also the patron of many organizations. So over to you, sir.
Thank you. Thanks, Jyoti, once again for giving me an opportunity. Thanks the committee, organizing and scientific committee. Thanks Medtronic for support. And what I am going to talk, the glycemic outcome in India with this pump which Jyoti was talking of. So in the next 20 minutes, I have a very important question, because most of the time when we ask the patient to go for the AID, the first question that will this automation be handled by our patients? I mean, the first question asked by the patients on the caregiver or the relative or even the colleagues and doctors, will they able to handle this? The second question, will it handle the Indian food? Because that contains a lot of carbs, and that is what the major challenge is there when you are saying that it is completely automatic. Will they able to handle this? And do we have the data? Can we get similar or a better patient outcome in India? Now, one side we are showing you the data of some of the European study. Recently he had shown you, the Jyoti had shown you the paper of 100,000 patients from Middle East and Europe. And do we have similar type of data or a patient outcome? Even we may have less number of patients, but do we have the data for that? So for these three questions, we know the relationship of A1C to time in range, and I am sure those who are using pump or continuous glucose monitoring for their patient, they know that more than 70% of the time you should be in time in range. But roughly those who are managing their time in range around 70, it is HbA1c is less than 7, and that's the reason we ask our patients, as well as any time when we are putting the persons on a continuous glucose monitoring, we want that time in range, it should be more than 70% of the time. This is the data when time in range had come. It was in 2019. It was published in Diabetes Care. I was lucky that I was part of this paper and I was part of this expert committee, that more than 70% of the any type 1, any garden variety of type 1 diabetes or type 2 diabetic patient who is coming to your clinic, if you put on a continuous glucose monitoring, more than 70% of the time they should be in remain between 70 to 180. But what about those who are elderly, high risk for hypoglycemia, frail? They should be still more than 50% of the time. They should be in that time in range. But definitely with pregnant lady, this time in range becomes more tighter. Even it is 63 to 140, whether someone is existing type 1 and type 2 diabetes or first time detected GDM. Now, these are the patients who are on continuous glucose monitoring. They should keep their time in range more than 70%. And then in 2019 onward, we had again come within 2021 one more term, that is time in tight range. So, you know, instead of going from 70 to 180, how many of time and how many percentage of time you are remaining between 70 to 140. This paper which we have published in Florence recently concluded meeting in ATTD, a long-term clinical outcome of the Minimate 780Z advanced hybrid closed loop system in India. And this was a modeling study which has been as a paper which we have done in this Florence ATTD meeting. What method which we had used? A long-term clinical outcome were estimated using IQVIA core diabetes model. A two treatment effect assumption were examined. One was randomized controlled trial where a reduction of 1.4% HbA1c was demonstrated by advanced hybrid closed loop system versus multiple daily insulin injection, that what he had shown already with CGM, with MDI, and patients who are put on advanced hybrid closed loop system. You can see there was a significant A1C reduction was there. And given India's current standard of care, which is not even CGM, it is only with MDI with self-monitoring of blood glucose. So it is further, less, which served as a comparator, and an A1C of no improvement was presumed. The other assumption was from a retrospective real-world data analysis with individuals in India, which showed that advanced hybrid closed loop system was associated with time in range was more than 75%. So whatever the number of patients which we were having, they were achieving time in range was more than 75%. To accommodate the model input format, time in range was transformed into HbA1c, that is less than 6. As I told you, more than 70% it is 6.7, or if it is 75% it will be around 6.5 as previously published, and a baseline HbA1c of 8.9, which I am taking for those patients who are averagely taking multiple daily insulin injection with self-monitoring of blood glucose, was considered as a local cohort. And this is what a long-term clinical outcome were estimated with the IQA core diabetes model, and this paper which we have published in this current ATTD. So modeling to estimate the impact of this mini-med advanced hybrid closed loop system 780Z on a long-term diabetes complication with IQR diabetes score model. So, we are using this only with 1 and 1.5 years. And this is a model which was calculated. If we use all those patients on a mini-med 780Z, what will happen to their complication? What you can see, the cohort profile with the mean age of 39.2, with the duration of diabetes was 15 years, with a male patient of 50% with a baseline HbA1c of 8.9. Time in range as a percentage was converted into HbA1c following a regression equation, and other input parameters were mostly using the default inputs from the model while localizing from literature where possible, and cohort was simulated for 25 years. So what will happen to them if we keep them on a 8.9 HbA1c, what will happen for their complication? And other side, if we put them on an advanced hybrid closed loop system, what will happen to them for 25 years? And what was the result? The mini-med 780G system, if we put to them, was associated with lower cumulative incidence of diabetes complication. Now, why we are showing this data? It's very important. We all understand that this is very costly, putting patient on a pump, then every month there is a 20,000 rupees expense. But if you see in 25 years, what we are trying to show the complication, cost of diabetes treatment is much less in compared to treating the diabetes complication. So the biggest cost is treating diabetes complication. For type 1, we have a type 1 index paper where they are not surviving even above the age of 30. Most of them are in late 30s, they are dying. They are already developing complications. So forget about their, the complication cost. Even they are not surviving after the age of 35 or 40. With this, for example, the cumulative incidence of neuropathy after 25 years of the treatment is 41% with a randomized control data, and in real world is 22.8% with compared to 69.2% patient who month. So it's not like that only for first month they are achieving the time in range. You can see from first month, second month, third month, continuously, constantly, they are achieving time in range for more than 75% of the time and no hypoglycemia. And below 54, it is hardly 0.4 to 0.5%. In conclusion, the real world data of 780G users in India demonstrated good glycemic control similar to that achieved in a developed country. So if I compare this data with persons with Germany or UK, the similar type of patients, they are also achieving around 75% of the time in range, and similar type of data we have from India too. Improved access to advanced diabetes technology have the potential to improve the glycemic control in more geographies, and some of which include low and middle income countries. So our two questions were there. Whether India will able to handle these automation, or these are type 1 children will able to handle the caregiver, having the one question. And the second questions were there from the we doctors, that whether we will able to this advanced hybrid closed loop system with so much carbs which we are taking in our country as a diet, will they able to achieve more than 70% of the time in range? And both the questions which I answered that yes, we will able to handle, and our patients are achieving time in range more than 75% of the time. This is the glycemic outcome of an advanced hybrid closed loop technology in children from India. This was a paper in 2022-23 in our Rotterdam meeting of SPAD meeting. Kulkarni was there from Mumbai as a pediatric endocrinologist. The objective of the study was the impact of Minimed on achieving recommended glycemic outcome in children 15 years of age or younger. The method that he had used, children of 160 with type 1 diabetes from India who use Minimed system, uploaded data from January 2022 to May 2023. So Mohan data was only for 6 months. This is almost for 17 months data. And for users, for more than 10 days of sensor glucose data with initiating the system, the time below range, I'm just coming to the conclusion, the outcome with it was almost comparable with European. So you can see the patients with post advanced hybrid closed loop system from India, 160 patients, the Europe data which is already published with 2,516 data patients, and you can see here we were achieving time in range, and these all were below the age of 15. These are the patients who are below the age of 15 with 71% time in range with A1C of GMI of 6.3, and again as I told you the hypoglycemia was 0.6, which was as comparable with the European data which here you can compare. The one more which was from again Dr. Jyoti Dev, he had published a paper on a real world user and a clinician perspective and experience with Minimed 780G, which is again advanced hybrid closed loop system. This was a paper from Jyoti Dev in his own patients which he had shown in a real world setting. With the 780G in Automate, his patients are achieving 83%. As he was talking about 2 days before, I had posted a photo of one child who was achieving 100% time in range. So that is what, just before 3 months we had put the patient on a pump, and now he's achieving 100%. That's the reason I had taken the photo and we have posted in our group. So Minimed data which he had shown, there is 780G in compared to MDI, and you can see with the patient with more than 80%, it's the 41 patient data which he had shown, and the time in range was 74.43 from this data. Their 6-month period which he had done, and the time below range, that is most important thing when you are talking of time in range in patients who are put on a insulin pump or on MDI with CGM. We are worried always for the time below range, and here it was 0.02% time below range, which is less than 54. The longitudinal analysis of 450 days. Now, this is a long-term data which I talked about last 6 months data every month, how much they are remaining in time in range. Here in first 90 days, it was 64, but you can see the fifth 90 days. It means the afterward, in 450 days, you can see it increased from 74 to 83% time in range for these children. 41, this is the longitudinal analysis from India of 450 days of those first 41 users of advanced hybrid closed loop system. Time in tight range, a target achievement with automated insulin delivery. This paper we are going to publish in ATTD, which will be in Asia, Singapore in 2024 in November month, and where myself, Manoj, Vinay from Medtronic and Jyoti Dev, we have combined, and this is what we are trying to show. The time in range is 75.92 and time in tight range. That's the first time we are trying to show that people with time in range, but what happens to those who are put on an advanced hybrid closed loop system, whether they remain in time in tight range, that is TITR, and in TITR also they are achieving more than 50%, and even some of them are up to 60% of that. So that's what more important. We wanted to also understand whether they remain more for time in tight range or not, because first we had shown the less hypoglycemia, then we tried to show time in range, and then how many of them are remaining time in tight range. One more paper which will be again for ATTD Asia, the same group, the Jyoti Dev is going to put this paper, the switching to automated insulin delivery system, a retrospective observational multicentric experience from India. Again, the 3 centers of us, and HbA1c of these patients after putting the AID, you can see significant improvement from 8.77 to 7.10 and plus minus 0.95. It means many of the patients were around less than 6.5 HbA1c also, and many of these patients were between 6.5 to 7, and they were before that the time in range was only 44.5%. As I told in morning time also when we were discussing for type 1 diabetes, A1 to D1, in that panel discussion also, most of the patients, even you put them on a CGM and you do multiple daily insulin injection, checking their sugar 4 times, 5 times, they are taking correction dose. So most of the time their time in range is less than 50%. But when you put them on a like a AID, on a system like a advanced hybrid closed loop system, you will find the time in range improves significantly from 50 to 75%, and most important, they don't develop the hypoglycemia too. One more similar data from these three of the centers. Manoj is going to have this paper that automated insulin delivery system does adjust to physiological change in Ramadan fasting. And now this is very important, that whether type 1 diabetes, if they do the Ramadan, like a prolonged fasting, whether in a real world data, those children who are type 1, who are put on a insulin pump, and we try to find out that each one of us may be having few patients, not many, but what happens to them for during Ramadan, whether they will have during Ramadan or during fasting stage also, will they able to maintain the time in range, and what happens to their hypoglycemia. And to our surprise, they were maintaining the time in range between 73 to 74%, but what is most important thing, there is no hypoglycemia. Even they were doing a Ramadan fasting, but there was no hypoglycemia, because the basal rate gets adjusted in such a way that even they are doing long-term fasting, I mean the full day fasting, still there was no hypoglycemia. And probably in next year, we may have a paper during exercise what happens to them and what happens to them for hypoglycemia too. So in conclusion, yes, automation can be handled by our patient. That is the most important thing, which I had shown you the data from India, and that has been compared. Automation can handle Indian foods. That's the most important thing, that we feel that they are more carb-rich diet which we have. Refined carb is more. Whether will they have better time in range, that is also there. And yes, we can also have a better patient outcome. Primarily in time in range, we are getting more than 75%. Time in tight range is also better. And there is no hypoglycemia in India in compared to other parts of the world. So we have our comparable data in compared to other parts of the world. To conclude my talk, thank you very much once again, and I invite you, all of you, for ATTD Asia meeting. First time ATTD is coming to Asia, which is in Singapore, immediately after our national meeting of RSSDA. It is 18 to 20 November. If you have anything in technology or you want to present at an international platform, this will be an ideal platform. And for India, for those who are interested in technology, we have our meeting in Jaipur. Organizing secretary is right here, Dr. Rakesh, and with founder Dr. Jyoti Dev. We have this meeting from 9th to 11th month, May on 2025 in Jaipur. With this, I once again thank Mohan for kind introduction, and thank you, Jyoti Dev, for this wonderful opportunity. Thank you, Medtronic, for support. Thank you.
So, chair is open for any questions. May I request Dr. Jyoti Dev sir also to come to the stage. So, just starting the ball rolling, what is your experience in the type 1 diabetic patients who go into pregnancy without any pump, started a pump during pregnancy, and following up afterwards?
So, individually, we don't have so many numbers. See, if you see the number of patients who are put on a AID on an individual basis, on an individual center, maybe 20, 30. At present, in India, we have around 1,500 patients who are on this advanced hybrid closed loop system. But we know that those patients, and I have put my personal experience, if you ask me, those who are interested that yes, she is going to become pregnant and she is okay, and she is already on an older pump, and now we have shifted her on advanced hybrid closed loop system. We have also that we have put her first time on advanced hybrid closed loop system, and then she became pregnant. The patient who are interested that, my sugar is getting a lot of fluctuation, and then we had, and some of the patients who are already pregnant, and then we had put on the pump also. So all varieties of patients, but not like in a data which we have, but definitely in coming years when we will have more and more number of patients with pregnancy and putting on pump, we will able to show the data. But I can tell you, they have excellent control. As far as time in range, it is roughly, most of my patient is around 80 or 80% plus. I mean 80% of the time in range. Now we are looking for time in tight range for these. Because the pregnancy, they require 63 to 140, not like up to 70 to 180. So that is what time in tight range. They absolute normal, full healthy antenatal checkup, and everything is fine with the newborn, no problem as far. But still gynecologists are too much worried. I mean, when you talk about the pump, when you talk about the type 1, they try to do, no, this patient cannot be, we have to do the cesarean only. They don't want to that till full term. So, you have keep on telling the gynecologist that there is no problem. Just forget that she is on pump, she is on this, her sugar is absolutely well controlled, and you do whatever you want to do, but forget about the sugar part. I will take care of this. So you have to continuously talk to them, but absolutely the results are very good.
Because that is the most important dilemma which we are facing. Because type 1 diabetic going to pregnancy, we have to have a tight control. They don't take proper insulin. They have a crave for food also. So they land up in more issues postnatally also. So I think...
But the pump is the best.
Pump is the best. Jyotis, sir, any points?
But Dr. Mohan, pump is the best. That I do agree. And that should be an automated insulin delivery. One good thing which has happened with this pregnancy is recently the American Diabetes Association has endorsed the use of CGM in pregnancy. So earlier it was not mandatory. So now we know that, as Dr. Banshi said, a stringent control between 63 and 140, and that too, if possible, more than 90 to 95% of the time. But it should be an interdisciplinary team effort. Extremely important that we should be working along with the gynec, along with the physician, or along with the pediatrician. So we'll be working together. But another area where we need to be careful in pregnancy is, it is preferred that this device is started when we are planning for pregnancy. So once they have already become pregnant, it is slightly challenging, because it takes almost 1 month to stabilize somebody on an automated insulin delivery. Because initially there could be some areas where you need to troubleshoot. You may have to change the cannula. In pregnancy, it is not the usual size where we will be deploying the pump. And it takes at least 2 to 3 weeks to get stabilized, and that time won't be there when the girl has already become pregnant. So if you are planning for insulin pump deployment or an AD in type 1 diabetes with pregnancy, plan it before pregnancy, when you are planning for a pregnancy.
Point well made. So any other questions from the crowd? I think we have some time for you. Any other interesting observation? Yes.
Dr. Hostam is representing Egypt, and he is a big leader in Egypt, and he is organizing a big program in Egypt, and that is PASIT, the Pan-Arabic Endocrine Meeting, where the technologies are also there in the title itself. And welcome again to India.
Thank you, Doctor.
Yeah.
I want to ask, how did you make this relation with the Indian president, and how did you increase the number of patients with insulin pump? Because the situation in Egypt, I think it is similar to India, but we failed to make this. Most of healthcare authorities and healthcare insurance are thinking only about the cost of the insulin pump and the cost of consumable, and they said, no, we will not support the insulin pump. Unfortunately, just after the COVID, one of the social organizations just gave 10 patients donation for insulin pump. Unfortunately, most of them are not well motivated, and the results from the insulin pump was more bad than the basal bolus. So this is reflected for the health authorities and health insurance that the insulin pump is bad. And unfortunately, the old generations of the doctors in Egypt thinking that insulin pump is fake and it is bad, and only basal bolus is good, and time range is just a fake thing. It is not important, just the A1C and everything. So I want to know from your experience how to change this culture based to the health authorities and all doctors.
So it's a very difficult question, number one, to change, and that doing a lot of advocacy. The one I will say that, more education program will definitely help to show the data that it's not fact, Like people, he had shown the data of 100,000 from Middle East and the data of Europe also, how they are improving. The second very important thing what you are saying is that they don't get insurance from this, but in India also nobody gets the insurance, or the third party is not paying, except few now started like ONGC or some government organization are started supporting some of these children if they have. But still, primarily it is only from the patient pocket only they have to pay. It is the doctor motivation that is more important. So out of, 40,000 physicians who are treating diabetes, maybe another 10,000 pediatricians who are interested also, they might be treating also type 1 diabetes, some 1,000 pediatric endocrinologists or 500 pediatric endocrinologists and 2,000, 3,000 endocrinologists. Out of them, if you just calculate, I don't think more than 100 doctors in India who are aggressively prescribing insulin pump therapy. Maybe 200, 300 doctors who are exposed to insulin pump therapy, maybe 1 or 2 patients. So it's not like that in India the situation is great and we have almost similar type of situation. But yes, still yes, we are improving, and I am sure in coming years we will have many more number of patients. Thanks to company like Medtronic who is present here, and thanks for their support, to do a lot of programs. That's also very important. So the scientific conferences, these type of meetings where you can talk to hundreds of the doctors, even in our API meetings, and thousands of doctors who are listening, and there we are showing these type of data. The second most important thing is a peer support. Like he has kept a program. In each and every meeting we do a similar type of program. Some type 1, motivated, highly motivated type 1 children or the adults, they talk to other type 1. So now most of the meeting in last 15 years, one thing which I can say that I have done some change, that now we talk about the type 1 and technology in our main, it's not like that in a workshop hall only. It is like in a main hall where we are talking. And every time in each such meeting, we also keep some program and we invite these children also and these young adolescents, and we do some advocacy program also. So in every time, like if I am doing meeting in Ahmedabad, I will invite some of the experts and we'll do with their local children. Similarly, he is doing with the here local kids and all this. So this will also increase the awareness, and I'm sure then they will go and ask their doctor, I want the insulin pump. So sure, I'm sure that the doctor has to give, otherwise he has to tell that, no, I'm not writing one, you can go and get it. There are, in India, the 20% of the population is very affording. They are very rich and they can afford anything. We have some patients, before a few years, they were going Mayo Clinic and US and UK, and they get the pump from there also. Like similar situation for semaglutide. Many of our patients who are bringing their semaglutide injection or like Minjaro now from Dubai or from US also market. So we have, population which is mixed population who are very rich, they can afford anything, and they are also, very conscious for their health, and they can get all these things. The knowledge and all these things are available on internet, and they can also read. So what you can do is more such program. We have already initiated one technology meeting where we all are coming in Egypt, and I am sure this will increase the awareness and people will be interested to get more about the continuous glucose monitoring and insulin pump. Jyoti.
Yeah, so the question was how to convince the policymakers, and that is what Dr. Banshi has actually presented in the beginning, the cost effectiveness studies. And there is also a Swedish study where 70G was tested, and they have proven a significant improvement in the quality adjusted life years. And this is all to do with the lifespan of the individual with type 1 diabetes. And when they are reaching a TR of more than 70 or 80%, they are not just living longer. They are living longer with no complications. And probably in a similar audience, we expect doctors who are working with the government, giving them advices, both in the center and in the state. And these are the guys who have to probably convince the policymakers that these are useful devices. And with these devices, our people with type 1 diabetes are going to have a near normal life. And that might take some more time, because Dr. Banshi and the team, we all work together, and we are trying to influence the government. But I think our own fraternity in Egypt as well as India, we should be convinced of the benefits. And for us to be convinced, we should be using at least 50 AD devices, or what do you say? At least 20 or 25 devices ourselves to see the difference which is happening. It is a phenomenal difference in the life, in the transformation, how it is transforming the life of a child or an adolescent with type 1 diabetes. And if it can be started early. So this is what we have to convince. In the state of Kerala, where the literacy rate is close to 100%, now they are not agitating for glucometers. They are not agitating for insulin. They are agitating and they are negotiating with the government for 70G. So there's a difference. So they are not concerned about insulin, because Dr. Banshi and the RSSDA with his efforts, we are all providing insulin injections, both basal and bolus, and also glucose meters and supplies we are continuously providing to whoever is needing. But now the request is only for 70G, because they have read and they have understood that this is reaching more than 70, and with all the other modalities including CGM, they can reach only up to 55 or 60%. That means again the life expectancy is limited. But with 780G, the life expectancy may even get prolonged when compared to a person without diabetes, and for
You were
obvious
saying
reasons.
about some 10 patients who were given the free insulin pump and now because their results were not improved. So what type of insulin pump they were given? Was it like a older pump? Was it sensor augmented? Was it AID? That also makes difference. So,
that could
we
be
have
older
to show
pumps.
also
The
that's
old
very
pump.
important.
Huge effort is
So the
required.
older pumps, then if they are not very motivated, they may not do anything. What about the looping? Because there are group of people in India who are very much pro looping also. So even they are using older pump and
No,
this
no,
is
the older pump.
they are also doing, but still the time in range is improving for them also. So those all factors are very important for them.
Dinu from
But
Medtronic
one
is over
thing which
there.
I tell you,
Can we have the device?
if you can convince even a one patient, the family member and the child, till she or he survive, they will continuously bless you. As a doctor, that my doctor was great that she had or he had convinced me to put me on insulin pump. Because the life completely changed. I can tell you. And when the next time she or he comes to your clinic or in chamber, you will feel, that whatever you have done in your last so many years, for 10 years, 15 years, and then you could convince this child or the family member for putting the insulin pump, the life completely changed. So we are doing for a lot of patients. Like the day before yesterday, I had shown a child which is only a 10-year-old with 100% sugar is well controlled. The family was so old, man, and they were, they will keep on blessing you that now my child will survive till without complication.
Yes, unfortunately, there is till now they are thinking, even those who can pay for the insulin pump, they are thinking that it is a magic. I'll just fix the pump and I will eat and I will do everything. I will not need to measure blood sugar. I don't need to make carb counting. I don't need to change the basal, do follow-up. And this is also one of the challenges that a lot of patients think that the insulin pump looks like will cure the diabetes and everything will be okay. So we have a lot of challenges in Egypt.
So
how to
any
solve
new
it.
technology
Yes.
comes, there are challenges
Yes.
to accept it.
Thank you.
Thank you, sir.
So if there are any more questions, any other points to add?
Yes, madam.
Sir, I want to just expand on what you have all explained. Talking about the policy matters, there is an article from July 4th in one popular magazine which says in the whole of South Asia, Thailand healthcare is one of the best. And all of us know that Thailand, they had undergone a lot of political turmoil. 11 prime ministers have changed, but they have been able to achieve a very good 99.95% of healthcare, very good healthcare, only because of health insurance. Okay, and the life expectancy in Thailand, they have mentioned as 80. And in India, it is around 73. For America and European countries, 79. So I would like to ask how, as a group, we all should ensure that our governments focus or implement the health insurance for the common man. Only then all these will become a very good practical reality.
Yeah, health insurance in type 1 diabetes is again challenging. Anything new in that
So
space?
one is, I don't blame that government is not doing anything. I say always that government is doing a lot of things. Whatever they are trying, they have, now they are taking care of all senior citizens above the age of 70. Some of the problems, common problem like cataract, the knee replacement, the bypass surgery, the angioplasty, all of them are in government hospital is free. Even some of the private hospitals are also recognized. And most of the state health, because health is a part of a state health government, and most of the states had already started taking care of all these things. But regarding type 1 diabetes, like first was the Kerala who had started giving even the free insulin pump also, they agreed that they will give. Now last time Rajasthan government has also decided to do it. But we don't have the infrastructure also in the government setup. Even the empowering the people for treating type 1, that's also poor. We don't have. There is no dedicated type 1 clinic. Like, in the Gujarat government, I am talking since last 3-4 years that at least tertiary care hospital and all medical college, they should have a dedicated type 1 clinic at least once in a week. So, the private setup is there, but not in the government hospital. Even the tertiary care hospital, All India Institute of Medical Science, they don't have the dedicated type 1 clinic. They have a diabetes clinic, They have a thyroid clinic. They have all different. So, unless these type of things will come, but I'm sure slowly things will change. Privately, from the organization point of view, if you talk from Endocrine Society, from Pediatric Endocrine Society, from Diabetic Society, we all are working very hard, and I'm sure in coming years, more and more people will get the benefit of it. What we are doing here is ultimately to improve the care for a person with diabetes. Why we are all here? To improve the care for person with diabetes, whether it's type 2, type 1. So we all are doing here is the advocacy work. And I'm sure this will change in coming year or maybe in coming decades.
Because the only solution in type 1 diabetes is technology. And without the use of newer technologies, we can never reach the set targets. And people need to be convinced. The governments and the insurances, they need to be convinced that this is the only solution. And I can see that she is also agreeing with me. The two friends from Maldives, you want to share? Yeah, please.
Yes.
Please. Yeah. More than 25 years, right?
Yes.
Yeah.
Yes.
And
Yeah.
diabetes, and you are representing Diabetes Society of Maldives.
Maldives, yeah. So we are basically the only NGO working for diabetes in the country. And since Sir asked about convincing the government and talking about advocacy and also about the health insurance scheme. So we have a universal health insurance scheme where like most of the treatments are free for, but we also have had a hard time convincing the government to acknowledge the latest technology, the latest treatment as well. Dr. Jyoti sir will be really well aware of what we have been facing through the camps that you have visited through. And if you can remember, the first pumps that we got were donated, second-hand pumps by JPEF, by Jyoti sir, and he donated 10 pumps to the country, and that made a huge difference in convincing the government. We shared the data to the government from the patients who received these 10 pumps. So we were able to convince the government that with the pumps, hospitalization improved, the quality of life improved. Even the patient themselves wrote how their quality of life improved to the government. So we were able to convince the government to let the tertiary care hospitals prescribe pumps and then to fund those pumps through the National Social Protection Agency, as well as deliver all the materials to be supplies needed for the pumps.
And 2 months back when I was there for the camp, I could find that 780G is now provided by the government.
Yes.
Congratulations.
Yes. So the pumps that you were provided were like 640G, I think. So those we were not able to use it, but the government was able to replace the 640 with the 780Gs. So all the type 1s who were previously on the second-hand pumps have got new pumps now, and then there are additional youth also with pumps.
Thank you for sharing.
But don't throw those older pumps. We have Mahak with us. She can
Yes,
teach you for the looping also. And
Of course.
some of your patients can be on those looping.
I have
and we
talked
can
to
do
them.
online also, not
Yes.
necessarily.
I have talked today with Mike about this.
Yeah, so thank you very much. I think democracy finally wins because I think time has also run up. So we have done a great job. Thank you very much, speakers. Thank you.